I took a batch viva, and one thing I tell you, I'm just discussing postmortem, doing a postmortem of your radiological performance. Hysterosalpingography. All of you, most of you had written, those students who gave me the paper, wrote hysterosalpingography in a pregnant woman. এটা একটা গান আছে, কানে কানে কথা বলো মুখে কিছু বলো না। তো এটা খুব হিট গান ছিল বাংলা। তো এটা তোমরা দেখো, ইট ইজ সো ডেঞ্জারাস। মানে এই হিস্টোস্যালপিঙ্গোগ্রাফি লিখেছো, এক হয়তো দিয়েছি কাউকে, কিন্তু প্রেগনেন্ট ওম্যানকে হিস্টোস্যালপিঙ্গোগ্রাফি করা কিসের জন্য করছো, কেন করবে, এই কোয়েশ্চেন গুলো তোমরা নিজেদের কাছে জিজ্ঞেস করবে। যে কোনো জিনিস স্মল, মানে একটা মেঘ, আকাশ, বর্ষা, এই দিকটা বৃষ্টি হচ্ছে, শান্তিনিকেতন মেডিকেল কলেজের ওই দিকটায় বৃষ্টি হচ্ছে না। ইউ মাস্ট হ্যাভ অ্যান ইনকুইজিটিভ মাইন্ড। আর এটাতে যদি কেউ মার্সি করে তাহলে তো ওকে নম্বরটা দেবে, কিন্তু এর কোনো ক্ষমা নেই। এটা একটা পোস্টমর্টম আমার অবজারভেশনে এসছে। আর একটা কথা বলি, যেটা আমি বরাবর বলে এসছি, যারা আমার সাথে প্র্যাকটিক্যালস করেছে তাদেরও বলেছি, বা এমনি তোমাদের ওপেন লেকচারে যে 2, 3, 4টে লেকচার আমি নিয়েছি, সেটা হচ্ছে ইউ হ্যাভ স্টিল 4 months, 10 দিন পুজোর ছুটি বাদ দাও, কিন্তু হঠাৎ করে মাঝে মধ্যে পূজার শপিং করতে চলে যাবে, এটা করো না। তোমার দাদাদের মধ্যে কিছু ছেলে মেয়ে, দিদিরা, আমি একটু শপিং করতে যাব, so please, these 4 months I'm still requesting you, আবেদন করছি আমি আমার তরফ থেকে, যে you have 4 months. And one thing I tell you, এক গাদা বই পড়বে না, এই বইটা ও বলছে ভালো, ওইখান থেকে নেবি, এসব করবে না। অ্যাভারেজ all books now are in the same at level, same level more or less. The Chauresia of yesterday and Chauresia of today, there is little addition. কি addition হতে পারে সেগুলো হচ্ছে ইমেজিং। সেই ইমেজিং এর তোমাদের জায়গাটা কম, বা কোনো ইনভেস্টিগেশন। বাদ বাকি এখন একটা পেরিনিয়াল নার্ভ একটা অন্যভাবে, মানে কোনো অ্যানোমালি আছে, কোনো কার্ডিয়াক মাসল একটা অন্যভাবে প্লেসড আছে, ইউ নিড নট ওয়ারি নাও অ্যাট দিস লেভেল। ইউ know the main things, main content to pass the examination. One thing, another thing is that you acquire knowledge how much you can at this small, মানে আমি 3 মাস বললাম, 90 দিন বলছি, 1 মাসে আমি পুজো যা আছে ছেড়ে দিলাম। এক সেকেন্ড থিং, যেমন তোমরা ভাইবা দিচ্ছ তখন সবাই মিলে এসে দাঁড়িয়ে যাচ্ছ, ঠিক আছে, তাতে গতি নেই। কিন্তু এই গ্রুপ স্টাডিটা রাত্রি 10টা থেকে 12টা, ইউ বি ইন গ্রুপস, 4, 2, 2জন 4জন মিলে একটা র্যাটলিং সেশন করো। কোনো সময় অস্ট্রোলজি করো, যখন এখন ধরো মানে তোমরা হেড নেক করবে, হেড নেক তোমরা ডিসেকশন দেখবে, স্পেসিমেন দেখবে, তার সঙ্গে সঙ্গে ওইখানেই 2 ঘন্টা বসে থাকো, 1.5 ঘন্টা বসে থাকো। ওই টিচার বলে দিল, ডেমনস্ট্রেট করে দিল, তোমরা বেরিয়ে যাচ্ছ। It's the content of face and the scalp, and today we'll be discussing on showing you the video today. And when you do the dissection of scalp or the dissected specimen you are seeing, you can gain some knowledge. You take it in your you tell Lambu, I call him Lambu or Suresh. You take it in your pen drive, view it in your laptop in a group. In between you have your books and keep on questioning each other. 2 hours, 3 days. কারণ সবারই একটা পদ্ধতি আছে নিজের মতো করে পড়ার, কিন্তু মেডিকেল সায়েন্স নিজের মতো পড়া যায় না। আর একটা কথা হচ্ছে এই টিম 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 টিম, সব সাকসেসের পেছনে টিম। সো তোমার একটা সিস্টার যদি তোমার একটা সোয়াব একটা ওটি টেবিলে কাউন্ট করতে ভুলে যায়, ওটা থেকে যায়, তাহলে তোমারও সিস্টারের উপর ডিপেন্ড করবে। কিন্তু তুমি দেখবে যে মোটামুটি একটা যে আমি 3টে নিডল নিয়েছিলাম, একটা জেনারেল সার্জারির কথা বলছি, অ্যাপেন্ডিসেক্টমি করছো, 3টে সুচার, মানে অ্যাট্রোম্যাটিক নিডল উইথ, মানে it is the suture with the needle, it is embossed in the needle. তো সেখানে সেই কাউন্টিং এর ব্যাপারটা থাকছে যখন তো টিম ওয়ার্ক ইজ দেয়ার। সিমিলারলি ইউ প্লিজ be focused these 3 months. These 3 months, everyone is there to help you. Even the department, don't bunk any class like this, and to compensate for anatomy or compensate your physiology, don't do these 3 months. You sit tight. আমি যেমন বলি যে মাদুর পেতে তালায় পেতে মাটিতে বসে বসে পড়ো, আর মাঝে মধ্যে একটু আদা একটু নুন দিয়ে খাও, ঠিক আছে? It has a very beautiful content. Most of you, if you view this and hear the video, you will be seeing that the facial muscles, because you'll be reading the mandible, the bones of the skull. Naturally, in your books, there'll be small red marks. এই যে মাসলের কোথায় কি মাসল আছে, এই ভলিউমটা বাড়ালে Actually, platforma muscle, a burn and a facial burn হলো এগুলো যদি কন্ট্রাকচারটা বেশি হয়, কন্ট্রাকচারটা বেশি হয়ে যায়, এখানে কন্ট্রাকচারটা বেশি হয়ে যায়। This is scalp. It's a very common place, and especially road traffic accidents are in the rise. Naturally, head injuries are very common, and the vascularity of the scalp is such at a minor cut, at a ছোট্ট কেটে গেছে, তখন মনে হবে profusely bleeding, and it is very hard to get a fracture of the skull. তাই জন্য শ্মশানে যেখানে গেছে সেখানে দেখবে বাঁশ দিয়ে ওটাকে মেরে ফাটানোর চেষ্টা হয়। তো এখানে তোমার যে ভেসেলস গুলো আছে, all the vessels from the face and the scalp, on the whole vault of the scalp, এরকম করে পেছন থেকে এরকম করে ব্লাড সাপ্লাই গুলো আসছে। তো যখনই একটা ইনজুরি হচ্ছে, যে স্মল কাট, সেটা তোমার প্রচুর প্রফিউজ ব্লিডিং করে। কিন্তু ইফ ইউ হোল্ড ইট লাইক দিস, a tight pressure or pressure bandage, then the bleeding stops. Even similarly, if you see a small tumor, you want to operate on this forehead or in the scalp, a sebaceous cyst is very common lesion, and that can be operated. Even কি হচ্ছে, তোমার অ্যাসিস্ট্যান্টকে বলবে you hold like this pressure, and then you make an incision, so the bleeding will be less. So with this anatomy, the scalp and the temple, the total, the skull, you will be reading the muscles and the gala aponeurosis and the temporal fascia and the temporalis muscle, the total layers of the scalp, skin, hair, fatty tissue. One thing I tell you, even in neurosurgical operations, like Professor Jackson, he is the head of New York ITN Jackson. He is a neurosurgeon, Bulpuna, he is a plastic surgeon, but he is an artist. One lady was operated twice in Chennai, Apollo Chennai. I told one of your batches. Okay. Now, the thing, her nose was broken, her zygomatic bone was placed, depressed, and at a bivakso মুখের shape হয়ে গেছিল। I happened to attend the workshop in Amri, Gold Park, and Professor Jackson, he did a live workshop. What he did is that he made an incision at this level, and এটা সেই টুপির মতো, যে মোটরবাইকের টুপি পরে না, সেই টুপির মতন পুরো স্ক্যাল্পটাকে এত দূর অব্দি নিয়ে চলে এলো, পুরো চামড়াটাকে নিয়ে চলে এলো। সেদিন থেকে আমার কিন্তু আর ভয় ভীতি কেটে গেল, যে ইট ইজ পসিবল টু ব্রিং দি হোল স্ক্যাল্প, লাইক গ্লাভস করছো, ইয়ে করছো, সেরকম স্ক্যাল্পটাকে তুমি নিয়ে আসতে পারো। আর তার মানে অ্যানাটমিক্যালি ইট ক্যান বি, মানে একটা দেখবে যখন ম্যাসাজ করে তখন তোমার স্ক্যাল্প ম্যাসাজ, এবার সেখানে তোমার ইট মুভস, এখানে এরকম করে তোমার স্কিন তো যে কোনো জায়গা থেকে টেনে পেটের থেকে তুমি টানতে পারো। ওকে, injuries and infections are common in these regions. So this is the scalp boundary. You've seen in the previous video, this superior nuchal line, superciliary arch, and the zygomatic arch is here. The scalp is a tissue covering the skull of the vault of the skull cap. The scalp extends as follows: anteriorly up to supraorbital margins, posteriorly up to the external occipital protuberance, and superior nuchal line on each side up to zygomatic arch and external acoustic meatus. Some extent of the scalp extends up to the superior temporal line. Some authors consider that the scalp extends up to the superior temporal line. এটা একটু মতভেদ থাকতেই পারে। This skeletal structure যেটা বলা হয়েছে in your video. Now, the extent is the anterior supraorbital margin, posteriorly external occipital protuberance, superior nuchal line, on each side zygomatic arch. Layered skin, subcutaneous connective tissue, epicranial aponeurosis, loose areolar tissue, pericranium. Now the scalp arterial supply is supratrochlear, supraorbital, superficial temporal, posterior auricular, and occipital artery. Now the arterial supply of the scalp, you can, when you will be dissecting, you will be seeing the vessels. Now, the nerve supply in front of the auricles, sensory, supratrochlear, supraorbital, zygomatic-temporal, auriculotemporal, motor, temporal branch of the facial nerve. Now, behind the auricle, sensory, great auricular nerve, cervical 2, 3, less occipital nerve, cervical 2, and greater occipital cervical 2, third occipital cervical 3, motor, posterior auricular branch of the facial nerve. Now, clinical integration, sebaceous, surgical layer of the scalp, black eye. দেখবে you একটা বাঁশ দিয়ে মারলো, কেউ একটা ঘুষি মারলো, তো দেখবে একজনের চোখটা লাল হয়ে কালো হয়ে যায়, 24 ঘন্টা 48 ঘন্টা পরে কালো হয়ে যায়, মানে it becomes a black eye. The blood, this thing, it trickles down and produce the dangerous areas of the scalp, safety valve, cephalohematoma, caput sagardam, scalp wound bleeding, and gaping wound of the scalp. Now, layers of structures, the scalp is made up of 5 layers. The skin, superficial fascia, the subcutaneous tissue, deep fascia, epicranial aponeurosis, loose areolar tissue, and pericranium. Menominic scalp, skin, connective tissue, aponeurosis, loose areolar tissue, and pericranium. Next. Now, this is a diagram showing the heads, the emissary veins going into the sagittal sinus. The sinus, these emissary veins drain into. Now, diploic vein in between the bones of the skull, the two tables. You will see if you see a cut, the picture will be like this. Okay, endosteal and meningeal layers of the dura mater. This is the dura mater. Now, dura mater, arachnoid mater, and pia mater. These are the coverings of the meninges of the brain. Now, why you have to be very careful of managing the wound in the head, that is the scalp, any dirt, you have to do a debridement and cleaning, because it is if it gets infected and if you don't give a good covering of antibiotics, then there are chances of meningitis. So, if you operate on the scalp, a small tumor in your clinic, please give a good antibiotic coverage so to avoid meningitis. Because of the anatomical disposition of the scalp is such. Now this is skin, connective tissue, aponeurotic layer, loose areolar tissue, and the pericranium. Next. Now again, it's a repetition. You can do, if you have a short note, 10 marks, short note, then you please try to do a drawing like this, not like the artists of Kolabhavan Shantiniketan. You keep on shading, একটা চুলটাকে নিয়ে একটু একটা হোয়াইট একটা গ্রে করে দিলে, হ্যাঁ, একটু ব্লু করে দিলে, হ্যাঁ, সোনালি করে দিলে, সেটা করতে যেও না। কারণ তোমার আমি বলছি pericranium, superior sagittal sinus, falx cerebri. Next. Now again, the layers of the scalp skin, hairy adherent to epicranial aponeurosis, numerous hair follicles and sebaceous glands. Now, the basic anatomy leads to the development of the cyst. If the sebaceous gland is blocked, there's a blockage in the duct, the subcutaneous connective tissue, superficial fascia, dense connective tissue passage for blood vessels and nerves. Epicranial aponeurosis called Gallia aponeurotica gives insertion to frontalis and occipitalis muscle. You have seen in the video that the occipital muscle is inserted in the Gallia aponeurotica and the frontalis muscle is inserted in the thing. এরকম করলে তোমার এই মাইন্ড তোমার যোগেশ দত্ত, হ্যাঁ, is a famous mime artist. Okay. Now, loose areolar tissue anteriorly extends into the upper eyelid, posteriorly extends up to the nuchal line, gives passage to emissary veins. Pericranium, periostem of the cranium bones and loosely attached to the bones. Now, এই যে লুজ কানেকটিভ টিস্যুটা এতটাই আছে যে হেমাটোমাটা হওয়ার চান্সেস বেশি থাকে। হেমাটোমা হয়ে যায়, ব্ল্যাক আই হয়, sebaceous is very common in the scalp. Now, some interesting facts: skin of the scalp is hairy except over the forehead. It is adherent to the epicranial aponeurosis by dense superficial fascia. Hence, difficult to separate the skin from the epicranial aponeurosis. It contains numerous hair follicles and associated sebaceous glands. Subcutaneous connective tissue, superficial fascia of the scalp, is made up of dense fibrous connective tissue that firmly adhere the skin with the epicranial aponeurosis. It provides space for passage of blood vessels and nerves. The walls of the vessels are adhered to the connective tissue, and the injury of the vessel will lead to profuse bleeding due to failure of retraction of the vessel. Now that I told you, that a small minor cut, হ্যাঁ, দেখবে টিভিতে মাথা ফাটিয়ে দিয়েছে, বরফ লাগাচ্ছে, লাগাচ্ছে, হ্যাঁ, এইরকম করে রক্ত ঝরছে, but you just put a band or tight, or you just press, then because the vessels in the scalp does not contract. Immediately they remain open. Naturally, if you press, দেখবে মাথাটা এমনি করে টিপে ধরে দেবে। Transport with a bandage, tight bandage. If you don't have the facility, তুমি ধরো গড়িয়াহাটার মোড়ে একটা চেম্বার করছো, সেই সময় মাথা দিয়ে ডাক্তারবাবু দেখুন, তো immediately you just tie a bandage and let him go to the hospital, refer to the hospital. Now, the epicranial aponeurosis is Gallia aponeurotica, is a fibrous sheet that can move on over the pericranium along with the overlying skin and fascia. It receives insertion of the frontalis anteriorly, exotic repetition, and occipitalis posteriorly. Attachment epicranial aponeurosis is attached to the external occipital protuberance highest to the superior nuchal line and superior temporal line. Now you feel your own occipital protuberance. and you just do like this. দেখবে মাসলটা কন্ট্রাক্ট হচ্ছে, okay, and you see the temporalis muscle, you contract, and you say এরকম করলে you see the things is attached there. Now loose areolar tissue, loose connective tissue anteriorly, it extends into the eyelids before frontalis muscle, does not have bony attachment. Posteriorly, it extends to the superficial nuchal line, laterally temporal line, and it passes through emissary vein that connects intracranial venous sinus and extracranial vein. Now, this is the basic. এখানে যদি মাসলের সাথে অ্যাটাচ হয়ে যায় বা মাসলটা যদি এখানে লুজলি না থাকে, তার লুজলি থাকে বলেই তোমার ব্ল্যাক আই হচ্ছে। The blood trickles down. Pericranium, it is the periosteum of the skull bones, which is loosely attached to the skull bone except at sutures where it is firmly adherent. এটা তোমরা যখন ডিসেকশন করবে দেখতে পাবে যে এই সুচার লাইনগুলোতে একটু অ্যাডিয়ারেন্ট থাকছে। Now, see the picture, the frontal bone is there, the frontal belly temporal branch of the facial nerve supplies this, the auricle epicranial aponeurosis, and the occipital bellies. Now, posterior auricular branch of the facial nerve supplies this. দেখবে এরকম যে দেখাচ্ছিল না, the contract, your occipital is and the frontalis muscle, surgical layers of the scalp, the first three layers of the scalp firmly adhering to each other are considered as surgical layers of the scalp or scalp proper. And superficial temporal region, it is the area between the superior temporal line and the zygomatic arch. And it is considered as a part of the scalp. It consists of 6 layers of follows. মানে এইখানে 6 layers থাকছে স্ক্যাল্পের, এইখানে 3 layers থাকছে। Now skin, superficial fascia, extension of the and temporal fascia, temporalis muscle, pericranium. Temporalis fascia is thick and fibrous sheet, and it represents the shell of bone. It can be used as a graft for tympanoplasty, that is the repair of the tympanic membrane. Now, the fascia, previously when these sutures were like proline or proline mesh, these sutures were not invented. In the due course, naturally this fascia lata used to be used as to repair hernias. Okay. Similarly, the temporal fascia is used. A small, you will be reading the bones, ossicles of the middle ear, and the ear, the drum, we say ear drum. Externally, if you put a stick or something or some injury or infection, chronic otitis media, there is a perforation, the earache, inflammation, and your pharyngitis, pharyngotympanic tube leading into the middle ear. Naturally, it bursts. So, কান থেকে, when the eardrum bursts, naturally the pus comes out from the ear, internal ear. Now, this is the pathology and the anatomy related. Now, ENT surgeons, what they do is they take a patch from the temporal fascia and they, under microscopy, they replace the eardrum, is lost. Actually, they place that, they do a tympanoplasty. Now, I told you the blood supply of the scalp, arterial supply, you see these are the major vessels. So you just have to, even when you suture, you have to locate. It will be even, it is from this side, So now supratrochlear artery, supraorbital artery, superficial temporal artery, behind the auricle, posterior auricular artery, occipital artery. Posterior. This can be a 4 marks question. Illustrate and give the arterial supply of the scalp. Now, supratrochlear artery is a branch of the ophthalmic artery, branch of internal carotid. It passes through the supratrochlear notch, medial to the supraorbital artery. Now, supraorbital artery is also a branch of the ophthalmic artery. It passes through the supraorbital foramen and notch and runs upwards. Superficial temporal artery is one of the temporal branches of the external carotid artery. It passes upwards over the posterior root of the zygomatic process. These you will be learning when you study the bones, also the arterial supply in the head and neck, and you can just this thing that the occipital artery is a branch of the external carotid branch, and there the above they mentioned all 5 arteries that are so fill in the scalp. Thus the scalp is a site of potential circulation between external and internal carotid. Now, anastomosis, naturally internal and external carotid artery at a pathway ache. Naturally, if there is a next. Now, venous drainage of the scalp is drained by the following veins on each side. In front of the ear, supratrochlear vein, supraorbital vein, superficial temporal vein. Behind the ear, posterior auricular vein, occipital vein. Next. Now again, the supratrochlear and supraorbital vein, they accompany the corresponding arteries at the medial angle of the eye. They join to form the angular vein which continues downward as the facial vein. Now, superficial temporal vein descends in the front of the tragus of the ear to enter the parotid gland. In the substance of the parotid gland, it joins the maxillary vein to form the retromandibular vein. It is also tomar face parotid jokon porano hobe. These actually the venous drainage of the head and neck, and lymphatic drainage. Now the lymphatics from the anterior part of the scalp drain into the pre-auricular or parotid lymph nodes. They are situated in the lateral surface of the parotid gland. The posterior part of the scalp drains into the posterior auricular or mastoid and occipital lymph nodes. Now, why? This is a very common presentation in children or a small baby. Infection in the scalp, scalpal infection is cured, but you have to, but the mother is coming and presenting you, the Dr. Dekhun ekhane duto tumor hoyeche. There's a tumor in my child's. Now, you you just see and ask the mother that did he have any infection, impetigo or some infection, boils, pora hoyechilo. Ever if she says yes, then you are sure that it is just an infection related lymphadenopathy. You directly don't go for a referency and excision biopsy or something like that. So this is a very common, previously it was very common, but nowadays the antibiotics and the children, they are going to hospitals or doctors earlier, as the presentation is there, but still you will get again, this will be continued tomorrow. I have a lecture at 9 a.m. Okay, now you will go to the practical classes, those batches who are going to practical. Now, today there will be revision on histology slides. Means the slides which will be given during exams or something, that box will be given to you. You view it in the microscope. If it is done after that, and if that lady becomes pregnant, that means that fetal loss will be there, because you are pushing a dye. The procedure is a bit painful, okay, and it is not done under anesthesia. It's a radiological outdoor process or procedure. Now, to see the uterine cavity, the appendages, the fallopian tubes, the cervical canal, because you push the dye with the histosalpingography cannula, and the dye goes through the tube, through the uterine cavity, goes through the tube. If there is no block, then it's spillage. This language is, this word is used, spillage in the pelvic cavity. It might be the right, might be blocked, so the dye doesn't spill, but on the left side there is spillage. The histosalpingography plate is very nice. You can again review. Okay. Now, in a pregnant woman, so you have to. Another thing is that uterine congenital anomalies. Uterine congenital anomalies. Say the uterus is developed from two Mullerian ducts. They fuse during embryogenesis. It gives the total architecture and the thing of the uterus. So that is bicornuate uterus or unicornuate, or just a single Mullerian duct has given rise to a uterus. That is, I showed you in my lecture that it gave a birth to a child, and I did a cesarean section. Now, you must be hopeful when you are prescribing. These are the things. So, not in a pregnant woman. You pregnant woman ki dekhbe? Already placenta, already sob ye hoye geche. You get a first ultrasound in the first trimester. You have done, suddenly you write, or even if you do for your PG clearance exam and the entrance exam PG, তুমি যদি ওখানে history done in 1, 2, 3 MCQ, you create a blunder. Okay.
Already you know the skull has got two parts. One, you can see the skull cap or calvaria. Taito. What is this? Calvaria. And this is base of the skull. But বলো না এখন তো interact করতে হবে. The base of the skull. Now, what is the difference between this skull cap and the base of the skull. Can anybody tell me? Actually, the calvaria or the brain box, it accommodates the brain. Calvaria means brain box. And this is the part, it is the base of the skull which actually differs from this part in their ossification. This part ossifies in membrane. It is called neurocranium. This part ossifies in cartilage. So it is the chondrocranium. You know the chondrocytes, cell nest you have seen, in the hyaline cartilage you have seen, chondrocytes you have seen, the cartilage cells, they remain in pairs, they form the cell nest. So it actually ossifies in cartilage. And we know there are several bones or immovable bones, except there is one bone, one cranial bone, which is movable. That is the mandible, which has got head and it is been accommodated within the mandibular fossa of this bone. This bone is, you must utter something, temporal bone on the temporal side. So there is a fossa which is for the head of which accommodates the head of the mandible. So which is called the mandibular fossa, which has got articular and non-articular area in the temporal bone. So all these bones are fixed. And in between the bones, we can see some zigzag lines or serrated lines. These are called sutures. One you can see sagittally, which is called sagittal suture, in between two parietal bones. One is coronal suture. You know, I think already you have some idea. So this is a coronal suture. There are also part of the joints. Joints are of membranous, cartilaginous, okay, and synovial. And here we can see there is a very little movement or no movement. Yes, there is a movement in the fetal life. When the fetus is going through the birth passage, during its journey, there is overlapping of the bones. one bone can overlap with each other. And there are some points. This sagittal suture, this is the coronal suture. So this meeting point is called the over the skull. This point is called bregma. Bregma. At least you have to remember it for next few months, unless and until you get the pass mark. Another point we can see the meeting point of two parietal bone and the occipital bone. That is called the lambda. Lambda. At least you should answer these questions, okay? Because the examiner or external examiner, when they will come, they will ask, what is this? Bregma. What is this? Lambda. So here we can see this suture from the lambda. This is the lambdoid suture. In between the occipital bone and the parietal bone. Similarly, this is a very important position, especially for the neurosurgeons. This meeting point of several bones, we can see this is a frontal bone, parietal bone. We can also see this is the temporal bone. And also we can see from wing shaped, the wing. There is a greater wing of the sphenoid. This bone has a funny feature. It looks like a bat with stretched wings and legs. So this is a greater wing, and also there is lesser wings. So if I can superimpose it, this is the greater wing. So this meeting point of frontal bone in front, parietal bone behind, and below we will get the temporal bone and also the greater wing of the sphenoid. So this point is called সবুজ জামা ওটা করো বলো না কিছু পারো চেষ্টা করো না কি আছে at least you have to try. This point is called pterion. Pterion. P-T-E. Not T only. P-T-E. The P is silent. Pterion. I told you this point is very important for the neurosurgeons, because inside of which we can see one very important artery and vein, that is middle meningeal artery and middle meningeal sinus. If there is a motorcycle accident, this is very much common. Most of you also ride the motorcycles. You may get injury over the skull, over the head region, and which has got Sometimes there might be shearing stress. That is the impaction. You have got helmet, but there is an impaction. The shearing force is there. There will be a definitely very good. There's a contusion injury of the brain, and there will be, what will be the result? This middle meningeal sinus or middle meningeal artery will get affected, and there will be formation of the hematoma, extradural hematoma. And that extradural hematoma, dura means, what is dura? What is dura? Brain has got the coverings. The outermost covering is the dura, then is the arachnoid, and most inside is the paya. Paya means the soft mother. It never betrays with the child. It always goes with the brain. The child means brain. It protects the brain. Our mother protects us like so. That paya matter always it moves through all the grooves. That means all the fissures and or which are sulci and gyri are there in the brain. So that is the paya matter. Most outside we will get the dura matter. Dura has got one inner lining which is called endosteal layer, and another layer is called, which covers the brain, this is a meningeal layer. And in between, we can get another space. Okay. So, what can happen here? It is outside the dura matter. The hematoma is there. And that is a neurosurgical emergency. Even the consent of the patient party is not at all required in that case, because it's a surgical emergency and you have to operate that one immediately without any consent. You can do it. You have got the right. If you are a doctor, if you are a surgeon, if you have got competency, you are competent enough, then you can open the brain through this area, through which is called bar hole surgery. Through that area, we can open up the cranium and we can immediately evacuate the blood so that we can decompress the brain from the compression effect of the hematoma. If there is compression effect, what will happen? There will be damage to the brain and the patient ultimately will go into the coma and ultimately the death. Talk and die syndrome. Suddenly, the patient will get the consciousness and go on talking, and you will feel patient is all right. No, patient has got the consciousness to lose it again. Talk and die syndrome. So, this is the Therian. So, what is the importance of the Therian? And also, inside that there is a temporal bone which accommodates the temporal lobe, which has got Broca's area of the speech on the left side. If you are the right-handed person, the left-sided temporal lobe is for your speech. That Broca's area of speech is also in close contact with this terion. So if there is an injury over the terion, that can affect the voice. আমি যে কথা বলছি কথা বলা বন্ধ হয়ে যাবে। That means the temporal lobe of the dominant hemisphere. If I am right-handed person, my left cerebral hemisphere is dominant, and there the temporal lobe is for speech. Broca's area of speech. There are other implications also. Okay, but I will mention only two. If you can remember these two, you will get the full marks. Then we can get another area here. The meeting point of parietal bone, occipital bone, and mastoid part of the temporal bone. If it is terion, it is opposite to the terion, against terion, so asterion. এগুলো তোমাদের পড়ানো হয়ে গেছে তো? হয়েছে? Joint of yes, joint of no. Craniovertebral joint. Yes. Yes, sir. No, sir. Joint of yes and joint of no. Atlanto-occipital joint. Atlanto-axial joint. দেখো হাসি মানে মাথা নাড়াতেও কিন্তু তোমার দুটো জয়েন্ট খেলা করছে। ক্রেনিওভার্টিব্রাল জয়েন্ট, ভেরি ইম্পর্টেন্ট জয়েন্ট ফর ইউর এক্সাম। সেটাও নিশ্চয়ই পড়ানো হয়ে গেছে, হয়নি, জানবে। So that is asterion. What is the significance of the asterion? Inside of which we can get the sigmoid sinus. We know there are dural venous sinus inside. One is superior sagittal sinus, which moves like this and ultimately goes down, and it is continued on the right side as transverse sinus. Then it is continued as sigmoid sinus, and ultimately that venous vein or venous sinus comes out of the cranium through the jugular foramen, and it is continued as internal jugular vein. So that sigmoid sinus, because there is a S-shaped impression inside, which is very much apparent. We can feel here in the occipital bone. This is the sigmoid, this is the impression for the sigmoid sinus. So this sigmoid sinus, we can see the impression. It is also present in the mastoid of the temporal bone and also in the occipital bone. So that sigmoid sinus is in very close relation to this area. So bregma, lambda, terion, asterion. And we can see this is the parietal bone. So the parietal bone, all the angles of the parietal bone, this is the superior angle, this is the antero-superior angle, this is the antero-inferior angle, posterior-superior angle, posterior-inferior angle of the parietal bone. We can see this is the parietal bone. All these angles are very important. Why? At all the angles, we can have a small area. After birth, we get at all these angles of the parietal bone, we can have soft filling. That means those areas are not ossified. If there is ossification, we can feel. What is ossification? Process of bone formation. What is ossification? The process of সবাই একসাথে বলতে হবে. What is ossification? Yes. সবাই যদি একসাথে প্রার্থনা করে সেটা পৌঁছায়. সবাই যদি একসাথে বলে তবেই কিন্তু মগজে ঢোকে. So at all these angles we get some area which are not ossified at birth, and those areas are called the fontanelli. Fontanelli. Fontanelli in a small, in a child, just if you are a newborn child, if you can feel the scalp, you can feel there is a soft area. তোমাদের আছে নাকি কারো? নিশ্চয়ই নেই, সব ইয়ে হয়ে গেছে. So those areas are called, now these are the areas where we can have. Why these areas are there? Because after birth there is increase in the volume of the brain gradually. So it will accommodate that increased volume. Second, during the journey of the fetus through the fetal maternal passage, there might be cephalopelvic disproportion. That means the passage, either fault is within the passage or the fault is with the passenger. Passenger means, cephalo means head of the fetus. Fault in the passage means the birth canal. So if there is disproportion, that means the birth canal is short, or the diameter, biparietal diameter of the fetus is more. So there will be a cephalopelvic disproportion, and there might be a chance of arrest of the journey. There are several arrests, type of arrests. Deep transverse arrest, okay, is one of the very important one. Deep transverse arrest. So to minimize that the cephalopelvic disproportion, nature has provided all this spontaneously so that one bone can slide over another bone and that head of the fucus becomes smaller and pass through the lesser pelvis. There is pelvic inlet, then there is pelvic outlet, and there is the passage. So nature has provided this opportunity. Purposefully, nature has kept this area unossified. And for our benefit, like the benefit of the doctors, of the clinicians, what is the benefit? We can feel the intracranial pressure. Sometimes there is increased intracranial pressure, which is called there are several types of increased intracranial pressure. There are causes of increased intracranial pressure. Okay. There might be blockage due to blockage of the CSF. There might be increased formation of the CSF. There we can feel the CSF pressure. So nature has given the opportunity to us to feel the pressure over this area. Pressure of the CSF, which is called hydrocephaly. Hydrocephalus. So here we can feel, and in all the angles we can see the fontanelles. Among them, this anterior fontanelle is very important. It remains unossified up to 24 months to 36 months. So during that period, we can feel the CSF pressure. We can even draw the CSF from this area. We can reach below that area, we get the dural venous sinus, that means superior sagittal sinus. We can enter inside the superior sagittal sinus and we can draw the blood from it. Parito? Huh? And also we can draw the CSF. Why? We can draw the CSF from the lumbar region. In case of child, it is not possible up to the age of 3 years. Why? Spinal cord ends in L1 in the normal, in adult. It ends in L3 in child. Or it might be more below that region. So, if we want to perform the lumbar puncture in a child, we may injure the spinal cord. So, up to 3 years of age, this is the area through which we can draw the CSF. সব তো একসাথে করানো যাবে না একদিনে, তাহলে তো একদিনেই সব হয়ে যেত। কিন্তু কিছু কিছু জিনিস যেগুলো বলা দরকার আর মনে হচ্ছে আমার বলছি। And this is the clinical, and there is another medico-legal importance. If you have got a dead baby, suppose you have got a dead baby, dead, mito, dead, mito, বুঝতে পেরেছো? লিভিং অ্যান্ড ডেড, মরে গেছে বাচ্চাটা, মৃত অবস্থায় পাওয়া গেছে। In that case we can find out the age, because we know it ossifies at around 2 to 3 years of age. It ossifies around 2 months. It ossifies at the 6 months. Like that. It ossifies around 12 months. So, by knowing the time of ossification, we can determine the age of the unclaimed body. Okay. কত বছরের বাচ্চা তোমার মনে হচ্ছে? 2 বছরের বাচ্চা। আপনার বাচ্চার বয়স কত ছিল? 2 বছর। আচ্ছা, হতে পারে, এর বাচ্চা হলেও হতে পারে। So that is the medical science which aids in justice, which is called forensic medicine, or so that is the medico-legal importance. Now, what is this? Occipital. What is this? The gross structures, gross anatomy. That is foramen magnum. Any doubt? How we can hold this bone in anatomical position? Actually, this foramen magnum, this foramen magnum remains horizontal. So we must keep it in a horizontal plane. This is the upper angle. This angle, superior angle, which forms an articulation with the parietal bone. So this superior angle will remain superior. এরকম নয়, আমি horizontal এরকম হতে পারে। শীর্ষাসন করলে এরকম হতে পারে। অনেকেই শীর্ষাসনে সেদিনকে তোমাদের ভিসারা ধরেছে, পুরো উল্টে ধরেছে, শীর্ষাসন করছে। শীর্ষাসন নিশ্চয়ই করবে না, অ্যানাটমিক্যাল পজিশনে নিশ্চয়ই আমি পাটা মাথায় দিয়ে আর এই মাথাটা নিচে দিয়ে পাটা উপরে নিচ করে করে নিশ্চয়ই অ্যানাটমিক্যাল পজিশন দেখাই না, অ্যানাটমিক্যাল পজিশনটা এরকমই থাকে। So the most funny thing that the holding of the urinary bladder in anatomical position was most frustrating. কেউ উল্টে ধরছে, কেউ বেসটাকে সামনে দিয়ে দেখাচ্ছে, এই এরকম করে দেখাচ্ছে, মানে কেউ সাইড থেকেও দেখাচ্ছে। বোনসটাকে যদি আমি এইভাবে দেখাই, so the external examiner will get annoyed, at least if we cannot hold this bone in anatomical position. So this is the anatomical position. How we can hold this bone in anatomical position? We can find this is a bevel lane. bevel length should be like this. Below and in front, we can see bevel length, যেটা দিয়ে খোঁচা দিতে পারো কাউকে. So that will remain in front and below. দুর্ভাগ্যবশত এটাও সেম সাইজ. Okay. So this is the বাহ খুব ভালো, very good. এসেই যাবে আবার. So this is the superior border, this is the inferior border, this is the anterior border, this is the posterior border. Okay. The anterior border, it articulates with the frontal bone. It articulates with the frontal bone. So this is also called the frontal border. The posterior border articulates with the occipital bone. So this is the occipital border. Okay. This is the temporal region, temporal border. Okay. Now, here what we can get, the most important thing is the two eminence. We can see two eminence, one eminence here, one eminence here. Which is apparent here. This is called parietal eminence. What is the importance of this parietal eminence? What is the importance of this parietal eminence of both sides? Which is called the biparietal diameter. BPD, which is very important for your obstetricians. This is the very important diameter through which the fetal head engages within the pelvis. If this diameter is negotiable, then we can think, okay, that passenger can move safely. So biparietal diameter. Okay. Next, কেন বলছে এগুলো স্যার, তাই তো মামুনি কি বলছে এগুলো? হ্যাঁ, যদি না হয়, scapulopelvic disproportion is the indication for severe scapulopelvic disproportion is an indication for cesarean surgery, definitely. কিন্তু নেচারে বহু কিছু হয়, আমরা কিছু জানি না. The meaning of obstetrics is we stand by. জানো তো, আমরা জাস্ট দাঁড়িয়ে থাকি. মানে এরকমও হয়েছে, একটা গল্প বলি, সব চিন্তা ভাবনা হচ্ছে যে সিভিয়ার স্ক্যাপুলোপেলভিক ডিসপ্রপোর্শন কি করে ইয়ে হবে, সবাই মিলে বসেছি, আমরাও বসেছি, বড় বড় ইয়েরাও বসেছে, আলোচনা চলছে. এই বাইপ্যারাইটাল ডায়ামিটারটা বড়, এটা ছোট, এইখানে তোমার there are several conjugates, you know, anatomical conjugates, obstetric conjugates. So two conjugates, we have already seen the pelvis. Okay, but মানে আমরা খুব সব ভাবনা চিন্তা চলছে, কি করে এটা চলবে, এটা কি সিজারিয়ান হবে, সিজার করা যাবে না, এর আবার ভালভুলার হার্ট ডিজিজ আছে, তাকে তো অ্যানেস্থেসিয়া দেওয়া যাবে না, এসব নানা রকম. Those who are not from Bengal, actually I want to impress one thing, The nature, what we'll do, we do not know. Actually, there was one case, we were seeing that there was a severe cephalopelvic disproportion. All the teachers, all the professors, they were wanting what to do, because the patient has got severe valvular heart disease, rheumatic fever, history of rheumatic fever, rheumatic heart disease. Okay, so in that case, cesarean section is not at all indicated. Okay, only the forceps can be given, but that is also restricted. There is restricted indication. What we are thinking, suddenly the matron came and said, hoye geche. So that severe cephalopelvic, in case of severe cephalopelvic disproportion, what nature does, we do not know. So this is the biparietal diameter. Okay. And what are the important features of this parietal bone inside? We can see some markings inside. One is in front and one is behind. This is for the marking of the medial meningeal artery and sinus. This is the anterior branch and this is the posterior branch. Medial meningeal artery actually comes out. It is from the medial meningeal artery. Okay. It is branch from the maxillary artery, which is again a branch from the ultimately external carotid artery, because external carotid artery divides into superficial temporal and maxillary artery. So from that medial meningeal artery enters through this foramen, which is known as foramen spinosum. So there are so many openings. This is the foramen magnum. This oval shaped opening, foramen oval, and lateral to that there is another opening, that is the foramen spinosum. From the foramen spinosum, actually that medial meningeal artery enters into the cranium and actually supplies the meninges. So we are getting the impression of the medial meningeal artery, anterior division and posterior division. It's a branch of maxillary artery, it's a branch of external carotid artery, this is a branch of common carotid artery. Common carotid artery is a branch of arch of aorta. No, on the right side, it is not from the arch of aorta. On the left side is the arch of aorta, brachiocephalic trunk. So always you have to correlate, otherwise you will forget everything. This is, at least you just tell me, what is this? Frontal bone. So this is the squamous part of the frontal bone. This is the orbital part, and this is the cerebral surface, and this is the plate which forms the division between the orbit and the cranium. This is the orbit. This is the orbit. At least you know what is this. This is the orbit. পরীক্ষার হলে সেটাও বলতে পারিনি বহুজন স্যার বলছেন, আসাদ স্যার জিজ্ঞেস করছেন পরীক্ষায় সিএনএমসি তে, হোয়াট ইজ দিস স্যার, at least. So this is, you must utter this thing. This is the orbit. It is formed by several bones, like frontal bone, like maxilla, like this is the zygomatic bone. we know this point, malar prominence. These are called the malar prominence. It is very much prominent in Japanese pupil. So this is called os japonicum. So this is the zygomatic bone. So this is the area, and here we can find the frontal process of the maxilla. The frontal process of the maxilla. Also there is another bone, this is a lacrimal bone. And in front we get the nasal bone. So ultimately also it is contributed by the greater wing of the sphenoid bone. Also by the lesser wing of the sphenoid bone, this area. And here we can see one aperture above and another aperture below, which is called supraorbital fissure, infraorbital fissure. So at least you must utter these things. Okay. So this is the frontal bone. This is the external surface. This is the internal surface. And over the internal surface we can see some rough area. Why this rough area is present here? Because it accommodates the front part of the frontal lobe. The frontal lobe has got sulci and gyri, and also it is covered with the meninges. So we can see the impression of the meningeal arteries. And this area is called the zygomatic notch, because it articulates with very important bone, which is the zygomatic bone. We can see this is the zygomatic bone, and over the zygomatic bone there is one plate which has got so many fenestrations or openings. Okay. These openings are called actually this is a plate of bone where we can see the so many openings. Dekhecho? There are so many openings. This is in middle there is one bone which articulates with this frontal bone. This is in middle, we can see this is the ethmoid bone, and this is the cribriform plate of the ethmoid. Cribriform means where we will get the several rents like mosquito nets. Why nature has provided this cribriform plate of ethmoid? Because this is the nasal cavity. You know, from the nasal cavity, the first cranial nerve originates. First cranial nerve means olfactory, that means which helps in olfaction or smell, which was lost during our COVID period, anosmia, because the virus enters through the olfactory nerves. So those olfactory nerves actually passes through these rents or foramina, So this nature has purposefully kept this foramina for the entrance of the first order neuron of the olfactory nerve, and ultimately they end in a bulb shaped area which is called olfactory bulb, from where the second generation of neuron starts. So this is the area where we can get a spongy bone, that is the ethmoid bone. So here this U-shaped area is the ethmoidal notch, where ethmoidal bone accommodates. Ethmoidal bone has got a disc-shaped bone which has got middle one septum, which forms the nasal septum, a part of the nasal septum. On both sides, if you imagine the disc, there are several compartments. Old tabletop, you have seen on both sides you are getting so many drawers. You can imagine that old table with the drawers on either side, and a middle there is a septum which is just like a ethmoid bone, and that bone actually articulates with this frontal bone, and these are the area where we can get the air sinuses of those bones, of that bone, which are called the ethmoidal air sinus. Ethmoidal air sinus. So frontal bone and the ethmoid bone actually forms the ethmoidal sinuses. There is another sinus which we can see, which is going through this area and ultimately here, which is the frontal ear sinus. So in this bone, we can find the frontal ear sinus on either side, and frontal ear sinus is very much affected during affection of the cold, common cold, and there is secretion inside. Actually, these bones are called pneumatic bone, where we get the pneuma, or means air. In X-ray, we will find the black areas. In lungs, you have seen the black area, that is the lungs. You have seen in the fundus of the stomach, there is a black area, because anywhere where there is an air, that gives a black shadow. So we get the paranasal sinuses. There are so many paranasal sinuses. One is inside the maxilla. This is the maxilla. Within the maxilla, this is the area. This area also accommodates the air, maxillary air sinuses. So these are the paranasal sinuses which help to keep our cranium lighter. So when these sinuses are affected, it is called sinusitis. রাজভোগ দেখেছো? রাজভোগের ভেতরে একটা গোল থাকে, ওই বড়িটা যদি বার করে নাও তাহলে হাওয়া, আর যে বড়িটা ফেলে দাও ওর মধ্যে ঢুকিয়ে দাও, তাহলে হচ্ছে তোমার সর্দি জমে গেল। হাওয়াটা নেই, ওর মধ্যে সর্দি জমে গেল। রাজভোগের মধ্যে তোমার সর্দি জমে যাওয়া। Similarly, it also happens here. Just is an analogy. Okay, এটা analogy just. ঠিক আছে? So we can find this bone also. This bone is the maxilla. This is called the maxilla. So maxilla here within a pyramidal shaped bone which has got one. There are so many processes. One is frontal process. One is horizontal palatine process. One is alveolar process. This is the alveolar process. Okay, just একটু আমি সহজ করে বলছি alveolar process which helps in accommodation of the teeth. Okay, so we can find the last teeth, that is the upper third molar teeth. Sometimes above this teeth we get a tuberosity here. You can find it a tuberosity which is called the maxillary tuberosity. During extraction of this tooth, we know the wisdom tooth, impacted tooth, where we do the extraction. So that maxillary tuberosity is intact here. If there is extraction, this maxillary tuberosity will get affected. So this is the frontal process. This is the palatine process because it meets with another palatine process of opposite side and forms a division between the nasal cavity and the oral cavity. This is the hard part of the hard palate, which is formed by this palatine process. And also there is a palatine bone which has got palatine process also, which is posterior 1/4 and this is the anterior 3/4. So anterior 3/4 of this hard palate is contributed by this palatine process.